It's excellent to be here in this delightful weather. And there's no better way, I think, to start the week than to have to give a talk about AI in healthcare. But actually, what I'd quite like to do is go back to Wednesday last week, when I was being shown around and spending time with Watford General Hospital. And I'm spending this month, before I start as Chief Executive full-time, going around the NHS, going around social care, seeing hospitals, GP surgeries, mental health trusts, ambulance services, pharmacists, dentists, opticians. I'm trying to see as much of the health and social care world as I can. So I was at Watford General, which is a hospital which is frankly just starting the journey of digitization. But they showed me something which was really impressive, slightly surprising, which is in their cardiac unit. They showed me that they were using an AI system called HeartFlow. And for anyone who hasn't seen it, I was really blown away. What it does is it takes the result of a patient's CAT scan and sends it off, has the data is de-identified, has an algorithm applied to it, is sent back, and the system works out the flow of blood through all the different bits of all the pipes. And it saves huge amounts of time, saves lots of further examinations, it saves the patient coming in repeatedly, it gets results faster and therefore more safely, more cheaply, and creates better outcomes. The benefits were obvious to the clinicians, to the patients, to the hospital. And the clinicians I spoke to were really happy to be using it. This was, for me, a really nice example of a bit of technology which had been well and smoothly introduced, where the clinicians, far from being resistant, far from displaying all the attitudes which people talk about in terms of, sort of being conservative and risk-averse, could instantly see the benefits and were really happy with it. So that, for me, was just a moment when the goal was really obvious, because that moment could be replicated hundreds of times over in different areas, in different contexts, in different specialties, in different parts of the process. And you can start to see, I could start to see what the future might hold. But before I go any further, I just perhaps want to explain how I got here, where I think we need to go, and then how I think we need to get there. So first of all, how I'm here and what NHSX is, because 6 months ago, it didn't exist at all. The point of NHSX is really to do several things differently. And for me, perhaps most importantly, because it is a joint unit of the Department of Health and Social Care, NHS England, NHS Improvement, working very closely with NHS Digital, it has an opportunity to pull together all the levers in the system so that they align in a way that has been difficult to achieve before. Because the system has long been filled with brilliant, committed people, but by having powers disaggregated into different bits of the system, so budgets in one place, regulatory powers in another, incentives and commercial structures in a third, it's meant it's been quite difficult to make sure everything is aligned to try and achieve the same result. We have a chance with the creation of NHSX to make sure that with those powers aligned, we spend our time actually trying to achieve the goal that we've been set rather than manage an impossibly complex system. And then secondly, as the Secretary of State, Matt Hancock, has said, he wants NHSX to be a place where health tech, the sector, can meet the NHS and they can come together. And he's also made clear that he wants NHSX to be an organisation which focuses single-mindedly on the user, making sure that the product benefits and is easy to use and designed for the people using it. And that is the reason why we're NHSX. That is the X in our name. And if you haven't seen it already, we've got a stand in the expo. I think it's stand 7. Please visit us. There's a survey which we're running about what AI you're developing, what AI you've deployed. If you haven't filled that in, please fill that in. So that's NHSX. But let me just explain why I'm here. So I've come at this from a slightly odd journey. I was ambassador in Israel for 5 years, where I saw what an incredibly vibrant, intense tech ecosystem looks like. I came back. For the last 4 years, I've been doing digital policy for the government, where I got immersed in AI and data from the policy perspective. My team in DCMS set up the Center for Data Ethics and Innovation. We set up jointly with Bayes the Office for AI. We worked incredibly closely with Tabitha at CogX and set up the AI Council. We put together the AI sector deal. I don't need any convincing about the potential for AI to achieve amazing things, all about the need to make sure that that potential is realized in the context of rules and norms that give people, users, clinicians, the citizen, confidence in how it's being used. But there's another bit of my journey I wanted to mention as well, and it's why one of the key drivers why I took this job, which is last year my wife had breast cancer, and we went through the NHS as a patient, and I went through with her. And we saw close up the brilliance of the NHS, the absolute commitment of the staff, the extraordinary thing that is the principle behind the NHS, top quality healthcare free at the point of delivery. But we also saw ropey systems. We also saw clinicians battling with their tech. We also understood then, as we waited and waited for things, how incredibly valuable it would be, for example, to be able to have a quick, accurate reading of a mammogram. So that's the background. Let me just set out where I think we need to go. First of all, I think there's a massive piece around making sure that patients get what they need from the system in terms of data. We need, clearly, obviously, I think it's something everyone agrees with, systems that can speak to each other, so that my wife's oncologist at St Albans can see the notes from her GP surgery in Watford, and vice versa. This is not a question of just of convenience or efficiency. It's a question of basic patient safety. I was shadowing in A&E operation in a hospital on Thursday, and a woman came in to the resus unit, and she was in a pretty terrible state, but she had in her hand, she was clutching a bunch of discharge letters from the last time she was in hospital. And frankly, it was only because she was clutching those letters that the consultant I was shadowing was able to look at them and say, that is the cause for what's going on with her oxygen saturation levels, and was able to tailor the treatment accordingly. Now, had she been unconscious, or had she not had the presence of mind to grab those discharge letters and hang on to them in the ambulance, the treatment would have been the wrong treatment, because the clinician wouldn't have been able to know precisely the condition that he needed to treat. So it was, for me, an incredibly vivid example of, or illustration of why making systems speak to each other is fundamentally about patient safety. We need clinicians to be able to access patient data wherever they are in the system, safely and reliably. And to do that, we need an architecture for the system so that data can sensibly flow around it. But it's not just data for patients, as you will know more than anyone, it's data for research as well. Patient data used safely, de-identified, or however we do it, but in a way that allows innovators, researchers, the sector, to be able to develop products to make the NHS better, safer, and more efficient. But if we're going to be able to do that, that requires us to put in place a bunch of stuff that isn't necessarily there at the moment. First off is obvious, it's access to that data, which goes back to the architecture, goes back to the way that systems talk to each other, that data can flow safely. Secondly, we need to do a whole lot better at curating the data. People talk rightly about the fact that the NHS contains an extraordinary, I mean unique in global terms, longitudinal data set. And it does. It has the potential to be an extraordinary asset. But at this stage, it's only the potential. Because as anyone who has worked with that data will know, that data is not curated to a degree where it can be easily used. It is not consistent. It's not done according to the same open standards. It's not recorded consistently to a high enough quality. And then there's a third piece as well that we need to get right if we're going to make sure data can be used for research, and that is public support for the mission. And this has fallen down at times in the past because it's been misdescribed, because it's gone off in difficult directions. And unless we can have a public debate, we can talk about what we're doing, we can wrap rules and parameters around what we're doing in a way that gives the citizen confidence, the citizen may well withhold that public support. And that will make the project fail. So I think I and my team, Indra, who'll be joining me on the panel in a moment, and the rest of the team understand the incredible importance of keeping the public with us. And then if we can get the data piece right, you can layer on top of it all sorts of exciting uses for AI. AI that can be used in ways that will improve patient safety, improve outcomes, help clinicians do their job, help the NHS bridge that yawning gap that's opening up in the future between demand and resource. The potential is absolutely vast. I was very struck as I go round the NHS hearing from clinicians not just that they want access to the data, that if they're on the ward they want to be able to see the GP record, but they also want help navigating it. They don't want a vast amount of data just dumped on them. They want some intelligent support in that. So AI can help them at that point as well, make sure that they get the right information at the right time. Image analysis, I talked about my wife and mammograms, but the potential for AI to help relieve some of the acute pressures in analyzing images is really obvious. But we've got these massive hurdles to overcome as well. The hurdle of making sure that the data is configured in a way that allows the AI to operate. Attitudes that will allow us to deploy this with the support of clinicians and the public. And it's worth saying, procurement models that actually make it possible to deploy the technology as well. I was very struck when I looked at HeartFlow, talking to the guys at Watford General, that if they weren't careful, if they didn't come to an arrangement with their local CCGs, that though it would improve outcomes, though it would improve patient safety, though it would make the lives of doctors and patients easier, the hospital could actually end up being penalized for using it because they were going to do fewer procedures as a result of it. And that is a procurement model which is not working as it should. So what are we going to do about all this? Well, on procurement, Simon Stevens, the NHS Chief Executive, last week issued a call for evidence for how we can do this better, how we can create models of procurement so that we do actually find ways to reward innovation that helps, rather than procurement structures which make it even harder to deploy. We need to create an environment in which AI and data innovation can flourish by creating the rules that allow it to flourish, the incentives that make it worth developing, the public support and the clinician support that understands what it is we're doing and likes it. In NHSX, we have said that our approach is going to be focused single-mindedly on standards and platforms. I'm very conscious, as I stand up to head this new organization, of the risk of central bloat. I don't want to create an organization at the center which is getting bigger and bigger. My job is actually to support the system. But I do think there are two jobs in particular that we ought to be doing. One is to be the guardians of and the enforcers of open standards that will make sure that systems can talk to each other, that interoperability isn't just a buzzword, but something which is built in to everything we do. And secondly, in platforms, to do the stuff at the center that it makes sense for the center to do, because otherwise you're just getting a whole load of different systems being procured or developed, each one doing the same job, replicating across the system. So whether you're looking at something like booking or screening, each of which there are common functions that ought to be pulled together in a common platform, I think that's an approach which makes sense. And then I think what we really need to be doing is creating a platform on which innovation can flourish. Creating through the interoperability, through the open standards, through the rules, through the procurement mechanisms that we develop, a platform on which innovation, which the sector on which you as innovators can know that you can plug in and make your innovation work safely and with consent and in a way that works for everyone. And if we can do that, then I think amazing things can happen. And that means, and this is going to require some self-control from the center, not us not trying to do everything ourselves. And so I did a blog a couple of weeks ago, which you may have seen, about our approach to the NHS app, in which I said we are not, the NHS app has been brilliantly developed. We've got well over 2/3 of GP surgeries signed up nationally. It has enormous potential. But I've said to the team, though you have done a brilliant job, we are not going to keep piling on functionality into this app. We're not going to make it all singing or dancing. We will keep it there. We will keep it going. And there are certain things that I think it makes sense for an NHS own app to do. But what we will also do is use the process of having developed that app to expose the underlying APIs, to create an environment in which innovators can themselves develop technology and their own apps that can sit on top safely, using the APIs with consent, and then we can see innovation really flourish. And that is an approach which I hope will underline the way that NHSX does things. And then the last thing we can do to build this future that I've talked about is having a really clear vision of where we want to get to. A vision which we can all share, where doctors, nurses and dentists and all the other staff in the system know that AI can be fantastically useful to them, far from risking putting them out of job, which is a ludicrous notion. It can help relieve the acute strain that the system is under, that patients can buy into the vision because they know that this is technology which is making their journey through their system safer and better and making them healthier. So I think there's enormous potential. I think we know what we need to do, and I think with the energy and enthusiasm and commitment of staff inside the system, inside my team, and inside the sector, we can really make progress. So thank you very much.
So we'll probably leave questions actually for Matthew after the panel in the interest of time, and to run this panel very specifically in the subject of data that Matthew alluded to in his talk. The next panel is entitled "The Future is Bright, the Future is Data," and to chair this we have from us Deloitte's head of healthcare practice, Sara Siegel, who's going to introduce our panelists. Thank you.
Good morning, ladies and gentlemen. I'd actually like to ask our panelists to come take their seats, please. And Sara, if I could get that chair, that would be awesome.
I'm Jean.
Good morning. Thank you all for joining. It's a great audience for such a terrible day weather-wise. I'm sure you all enjoyed hearing from Matthew Gould. We're going to use this panel to draw out some of the issues and challenges, and most importantly, the opportunities that spring from greater use of our healthcare data. I'd like the panel to introduce themselves. I'll start. I'm Sara Siegel. I lead Deloitte's healthcare practice here in the UK. We do advisory to the NHS, and we also develop our own AI and robotic tools for use within the NHS that help to improve quality and reduce variation in common NHS processes. Shall we kick off with Andreas?
Thank you. Good morning. My name is Andreas Haimböck-Tichy. I head up IBM's healthcare and life sciences business here in the UK. In terms of what we do, and I guess why I was asked to join, is it's all about the data and how to exploit it, whether it's through standard means or increasingly AI. And we do that by helping NHS organizations and others to move to a cloud environment and make sure that we do that in a secure and safe way and keep the data safe when it's there.
Hello, everyone. I'm the CEO and founder of Lifebit. So at Lifebit, what we do, we basically help different pharmaceutical companies, research government organizations, and biotech companies to literally make their systems and their sort of like data AI ready. We basically take the full cycles from when the genomics data are coming from the machines and all of the different multi-omics data, and then basically we provide all of the software technology needed to analyze this data, to get first and transform them to informative data, and then from that point on, we provide a second sort of like AI-based software capability where we allow them to now integrate all of this multi-omics data with other phenotypic and clinical data to get into impactful and actionable insights.
Hi, morning everyone. I'm Indra. I'm also part of NHSX. Matthew, I felt you needed to do a bit more Xing. As Matthew's alluded, I sort of lead on the AI strategy, and on the other side, I also lead as the clinical lead for what we currently call Empower the Person, so all the patient-facing technologies, like the app, like the apps library, and some of the standards behind that.
Hi, I'm Jean, CEO of Clarify Health. So it's a pleasure to be back in London. I was here for about 10 years, working mostly in and around NHS London. Went back to the US, and essentially what we do at Clarify is we are one of the 5 or 6 institutions that gets all of Medicare's data fully identified across the hospital bills, out-of-hospital bills, drug bills. And we have figured out a way with technology to go between de-identified and identified data to union it with all of the commercial insurance, prescription drugs, lab data, soon to be genomics data on 200 million individuals in the US. And we run that through the same platforms that are used by JP Morgan and Goldman Sachs to then do far more precise individual risk stratification, so predictions of how patients are going to do in their journeys, and use sports analytics to look at the performance of physicians and to say who's created versus destroyed value.
And you met Matthew. So as you can see, a very eminent and varied panel, small startups, big companies, public and private sector. I'd like to kick off our questions by talking about the promise. Now, Matthew's touched on this a little bit in his opening remarks. There's so much that we could be doing with the data that's already at our fingertips. Indra, would you like to kick us off by talking about some of the things we could see from healthcare data?
Sure. So, I mean, there's lots of things. I mean, I'm not going to say anything that most of you in this room haven't heard, and I'm just going to say really quickly that the people at the door, you might want to come around this way a bit. There's some space here as well. So one of the things I would say that we could look at is population health. I think that's probably where we'll see some of the biggest impact. And I'm also slightly conscious as a doctor of health inequality when it comes to data. We mustn't ever forget that not everybody is the population we have in this room. Having worked up the road at the Whittington, there's a very different population, and also down the road at UCL, who don't have the kinds of technology that you guys in this room might have. So we must look at also population health. And the other thing is, I mean, it's a no-brainer, isn't it? But we talk, is that me in my pocket? I'm going to stop doing that. is imaging and diagnostics. So already for a lot of years we've been collecting really good imaging data as well as diagnostics, so let's not forget pathology. So I think we'll see some really good stuff there. Matthew alluded that we're doing a survey, and the reason we're doing a survey is we want to know exactly what people are not only developing but deploying, because we talk a lot about development in AI, and those of you who are developing stuff, we're still some way from deployment, and if we want to make the impact today, we need to know what's actually being deployed today for us to start looking at how we can make those changes on the front line.
John, do you want to add to
Yeah,
that?
from where we come at it, the things that we're trying to enable, just to give you a couple of concrete examples, social determinants of health, we know in several conditions often have a much greater impact on the journey of the individual than their actual biology. So to give you an example, if you go and use the same credit card information, information that's used to determine whether you can get a mortgage or not, and apply it to healthcare, you can then do analytics that allow you, for example, to say, hey, this patient coming in has food insecurity because he or she just lost their job, therefore sending them Meals on Wheels is actually the most important intervention that you can have. Or somebody's daughter just moved more than 5 miles away, and as a result of it, they're not going to be able to get to their care, and their risk of readmission just went up from 5% to 25%. Bringing that kind of analytics to the workflow of care is an important addition to the kinds of technologies that were mentioned earlier around, specific tests, for example. So in our minds, it's the combination of effective workflow with the deployment of the right technologies in that workflow.
So there's a lot of challenges that we have in our healthcare systems. Growing workforce shortage, growing strain on budgets and other types of resources, poor quality or high variation in quality. Can data help solve some of these challenges? Andreas, do you want to comment on that?
So yes, I think it can. A couple of areas, as you say, I think it's how do we use the technology to create better, safe outcomes, and how do we make things more sustainable? So one area is clearly around variation, and Indra just talked about populations are different, so is care. So if we really understand what the best treatments look like, we can make sure that those become available everywhere. And that's, I guess, what we as individuals, what we as patients all want. We want the best care from the person in front of us. The other point where I would say in terms of sustainability, and unlike other industries, I think in healthcare, we're not using the patient, we're not using the citizen, the customer fully enough. And that's an area where we've done a lot of work. And again, I think Sean just talked about social determinants of health. What we've learned through some of those deployments is actually what type of questions patients have. And Matthew spoke about cancer earlier, and one of the use cases we have deployed is where people can ask of the AI digital assistant what questions they might have. And a lot of these questions are not medical questions. They're things like, can I drink while I'm on chemotherapy? Which is not something people want to ask in public, but they might find out that way. Or they've got other issues like, who's going to take my child to school? So it's those type of things and actually empowering the patient and giving them the data.
Yeah, brilliant.
And maybe on that, a comment as well. Like we tend to, a lot of times sort of like neglect genomics and the multi-omics dimension of that. And a lot of times, even when it's brought onto the table, it's just brought from like a health perspective of like, what is the mutation that's going to kill you? But it's so much more than that. That encompasses all of the information about you. And I think once people are starting to get that information and combine it with other environmental data and other health data, then they are much more empowered on their day-to-day lives to make better decisions, right? That will mainly work on prevention.
Brilliant, thank you. So many of you have already mentioned social determinants of health and the importance of what's going on in the rest of a patient or a citizen's life. I might put this broader question to you, Matthew. we're here, we're probably all in the healthcare industry, but it seems like it's not just for us, this question. What can NHSX do, or government in general, to help bring these different disparate data sets together?
Sorry, the data sets, social and medical.
Yes.
I think it's a totally fair question. I mean, to be honest, my initial task is just to bring together the medical data sets, and I think that's going to be a sufficient challenge. I mean, obviously, you then want to try and, I mean, the value of the longitudinal data set across the NHS is the fact that it goes into things other than just the sort of narrow individual sort of clinical episodes that pop up. And if you could find a way to try and bring in some of the sort of the wider data, I think it could be incredibly valuable. I was talking actually to John Poolinger, the national statistician, about this last week, and how we might, with the ONS, NHS, and UKRI, together try and do something quite big and exciting in this area. If you could do it, if you could find a way to draw in safe ways on these wider pools of data for research purposes, the good we could do could be very considerable. But the challenges obviously are all the challenges I talked about before multiplied. So I think, I mean, I'm very conscious at the moment we are trying to consume an elephant. We're trying to work out what order we eat it in. You've just sort of added a further set of elephants to the menu. So I think we just need to work out a sensible way of doing it.
Alluded to some of the risks or challenges with greater use of data. So I'd like to turn the conversation to that now. Indra, perhaps you could comment on what some of these risks are.
I mean, the risks are well known, isn't it? So if you look at the flow of a journey, you talked about the pathway. I would say number one is putting data in. So as a clinician, quite often, I'm not bothered. I just don't get, I'm not going to swear on a panel. I don't care about inputting data. I care about the person in front of me. And actually, although it gives me time to think when I'm writing in my notes or I'm putting something in the computer, I can't be bothered to find, what is it, chest pain, what was the cause of the chest pain, and go down that box. You know, these things have to be designed better. So that's a risk and a problem because we input the wrong type of data. And then you go back to the usual challenges around governance and the ethics around some of the data. You know, I know there's lots of ethics panels as well where we're going to be talking about this. But in health, quite often, I think that is a problem that we don't always think about, especially when we're designing systems. And you know, there are lots of examples which I won't name on the stage, but a lot of us know of them, of where people are determining things or inferring things on data that you might not known that was already collected. So I think we've just got to be slightly careful about the governance of data. We've done quite a bit of work around that, around how we develop what we call codes of conduct in the ethics of data.
Last week, Matthew mentioned Simon Stevens had a call to evidence. I was in the room when he made this announcement, and he took some questions after. And except for one question on Trump's visit, all of the questions were about inclusivity. Now, that's another big challenge with health data. How can we make sure that people aren't left behind, people who aren't as digitally enabled? Matthew, do you want to comment on that?
So I think there are two angles to this. So one is about access to the technologies. And the truth is, so in my last job at DCMS, we had the government's digital inclusion team. And this is a really thorny set of issues because there is a proportion of the population who don't access the internet. Some of them can't, some of them won't. There are different issues to do with access, attitudes, capability. There are various reasons why different bits of a population find it hard to access anything which is through the internet. And we need to be alive to that. And I think there's two angles to this. One is to try and bring those people in where it is possible. So to provide the access, to provide the skills, to provide the hand-holding in the right contexts so that some of these excluded populations can access technology digitally, but also to make sure that there are alternatives. So that, for example, Matt Hancock has said that the non-digital alternatives need to be at least as good, because the populations which are least able to access technology digitally are also those populations we most need to provide services to. So if all we're doing is providing services to the most digitally able, then we're excluding precisely the people we most need to help. But there's a second angle which I just want to mention because I think it's important, which is the algorithms themselves and the data themselves. Because if we're not careful, we model the algorithms on particular bits of a population, and we build in biases and skews which are themselves exclusionary or damaging. So we need to make really sure that as we develop solutions in data and AI, we don't accidentally, through the choice of the data sets we're using to model the AI, importing all sorts of biases that were there before. And that will require conscious effort, and it will require us collectively, the sector, the NHS, society, Parliament, to have an understanding of what the rules of the game are so we don't lose people's faith along the way.
Important point. There was an article over the weekend in the FT about the Home Office and the algorithms that it's using for visa processing. I think the watch out is a very important one for health. I wonder if any of the rest of the four of you, who I imagine have worked with algorithms in health, could comment on how we could steer ourselves a bit better.
You go ahead.
I think when we think in terms of like how are we designing algorithms, especially how we're applying AI onto that, we need to be thinking, we need to be like mindful about what is the data representing, right? And the data will be having certain sorts of like constraints that we need to be aware, right? And as such, when we design anything that is handling this data, then like the design of that should be like basically more aware of like what are the limitations, especially when we look at it from a perspective of like for example, like when we have genomic data from a particular set of population, then definitely we're not getting all of the information that we need to predict rare diseases, for example, in another set of population, right? And there are initiatives right now in London happening to make sure that we're going beyond the 100,000 genomes that we did with the Genomics England project to especially, you know, like categorize and get data from other types of sort of like subcategories. And I think that says quite a lot, informs inclusion, first of all. It definitely empowers people that comes with lower incomes, but also then it makes the algorithms much, much more representative and everything we build, because everything we build, it depends on the data at the end of the day.
Okay.
Maybe two things to add for me. So one is around transparency and explainability. So while as you know, as users of AI or data tools, we don't actually need to understand how they do what they do. We need to be able to track back what types of data and what inputs have been used so that we can reassure ourselves that those are the appropriate sources. The other piece is that actually to address the bias piece, we've now got researchers in our AI division working exactly on that. You know, how to detect the bias and, you know, give people tooling that they can use on their algorithms to sort of sense check them against that.
Yeah. Thank you. Indra, yeah, go ahead.
So just in a practical perspective, what we've done is, with a whole bunch of partners, some of whom I can see in the room, is develop a toolkit for explainability of your algorithms. So we wrote a code, some of you might have seen it, it's Principle 7, they're in my head. Principle 7 is, what does your algorithm do? Where does the data come from? Have you ethically examined that data? What's the bias? But also, what happens when you deploy that algorithm? And I'm no clever person when it comes to algorithm, but actually people like the Alan Turing Institute and some big tech firms have influenced how that works in real life. So do watch out for it. We're still tweaking it and trying to make it a practical toolkit so that when we're looking at deploying these algorithms or these systems into the real world, how can we assure, we talked earlier about the workforce, but how can you assure the workforce and the people who these algorithms might be working on that actually it's okay?
Wonderful. And sort of leading on from that, there's a lot of discussion, especially in the UK, around information governance and making sure that data is used appropriately. How can we balance those concerns with the need to use data more widely, both for research, managerial purposes, and direct patient care? Indra, do you want to have a thought on that?
I mean, we're quite lucky in health that we have the HRA, the Health Research Authority, which does look at exactly that if you're using data for direct patient care or research purposes. How do I put this delicately? IG is basically as good as the person who interprets it sometimes. And quite often there's a man in a room, and I say a man because it is quite often a man, I'm sorry for the men in the room, who's just like, oh no, I don't believe that, no, definitely not, that's not safe, And that's it, a project is stalled. And so I think we have a responsibility as a central system, but also with some of our regulators like the HRA, to be quite clear on what IG means in that particular situation. So we've worked quite closely with the NDG, which is the National Data Guardian's Office, to just clarify some of the rules, some around GDPR, some around the Data Protection Act, and some around our duty of confidentiality. Like, some of these don't always match, but how do we actually break them apart so actually it works from a governance perspective for whatever the solution is?
Brilliant. Now, Matthew, in his opening remarks, alluded to how important it is to create a health economy where there's great collaboration between the public and private sectors and the health tech sector. It would be great to hear from our two startup-ish members of the panel how you think that can best be affected.
Yeah, sure. So what's helped us, in fact, we wouldn't exist if it weren't for the two things in the US. One, the governance regime around data. So it's known as HIPAA. And essentially what it says is if you are a covered entity, so an entity ultimately providing care to the patient, you are allowed to use pretty much any information there is, including identified, so long it's used for, one, the purpose of improving patient care, and two, and obviously this being a claims-based system in the US, for the purpose of correct payment. Now, if you cross the line and start using it for marketing purposes, they'll come down on you like a ton of bricks. But as a result of that, we don't have to be in a regime where we have to apply for every use case that we do. We have an agreement directly with the hospitals that we work with, and then we can pretty much go after any analytics use case that is for the purpose of improving patient care. As a result of that, private funders, private equity, et cetera, are encouraged to invest behind startups because they can scale. The second is that Medicare, so that's care for over 65s, very quietly about 5 years ago made it possible, if you went through a very rigorous application process, takes about 2.5 years to get through all the security hoops, about $3 million to apply, but then you get all of their data with a 3-month lag. And so think of it as the mother of all APIs to data, if you will. Those two things make it possible to build a platform as opposed to a single use case company.
I think I would agree. Like in general, like basically somehow the government structuring the data and access to the data, and then making it easy, especially for younger startups that do not have necessarily 3 million to pay in 2.5 years to go for it. I think that's I would say would be the most important thing. Other than that, I think UK and in general with all of the different grants and Innovate UK and all of the different other sort of like grant schemes are trying to help quite a bit. It's just that I would say still access to different data is very, very difficult. And that in any way that could actually be facilitated, that would like unlock quite a lot of potential. Then we had a lot of discussions and concern of like, oh, the data is still a potential and we cannot deploy things, and what can we deploy? Well, we're not going to be figuring that out if we don't get access to the data. And we, like the majority of the younger startups hold most of the innovative technologies. They are the crazy ones that will come and will try to deploy things that no one else would do, right? But if you don't give them access to the data and if you don't make sure this data is standardized in particular ways, then that's not going to happen, basically.
Thank you. Okay, I'm told we have less than 1 minute, so I'm going to close with a series of rapid fire questions. The idea here is you answer in less than 1 sentence and you say the first thing that comes to your mind.
Twitter.
Andreas, what is the coolest unorthodox data use that you have seen?
Well, since it's raining today, I think I'm always amazed how much the weather has actually impacts health and how we can use that as a source into how we develop treatments.
Thanks. Just one question. Matthew. What can we learn from another sector of the economy that we could apply to health?
So not another sector, but another country. I was ambassador in Israel. The Israeli HMOs have really cracked interoperability, really cracked predictive analytics on the basis of the data, and it's amazing to see.
Maria, what's the single most important use of data in a healthcare setting that we have not applied yet?
Oh, so many. I would say more sort of like integration of data to sort of like create like a digital twin pretty much of the individual, where we can start then questioning different things. I would say that would be the holy grail, which means so many other applications.
Thank you. And Indra, when we look back in 5 or 10 years at this conversation, what will we be most surprised by?
Crikey. The first thing that came into my head was, oh my God, why were we making such a fuss? So maybe we'll have some really whizzy things in 10 years' time.
Amazing. And spin on that for John to close. What do you think is the single most revolutionary thing that data will allow us to change in terms of how healthcare is delivered?
Personalization.
Awesome. Can we please thank our panel?
Thank you.